So I'm going to talk a little bit about how the situation looks like on the ground. So now we've talked a lot about theory and what we're trying to do, and I'm going to share with you some experiences that we actually see with patients as they're undergoing treatment with TMS at our unit. So as it was mentioned before, different studies report the efficacy of TMS treatment as somewhere between 50% going all the way up to 80%. Here we're talking about adequate response, which is defined as above 50% improvement in symptoms. And so in our clinic, what we typically achieve is something that 77% of patients reach this adequate response. And we see improvement in all symptom dimensions except for anhedonia, which is something, it's a big topic, and we're going to talk a little bit about that today. What's interesting as well is that a lot of times when we do see improvement in patients, some of them feel that the improvement is not large enough. So they will anecdotally report that the TMS therapy wasn't effective, but when we sort of look at the objective measures, there has been at least some change. What we're very good at is we see a very large improvement in their cognitive functioning. So András has programmed a very difficult and complex NBAC task. It's a working memory task. And so here we see different conditions. So participants always see a grid, and then they have to pay attention to either a letter in the grid or a location within the grid. So we have a spatial and verbal condition, and people have to remember what was the identity of the stimulus 2 trials back. So stated like this, it sounds simple, but participants tend to be very flustered with the task. And so what we see is that before treatment, patients tend to have a very low performance on the verbal 2-back task, and that's sort of, we see a very significant improvement to after treatment. So there's a huge improvement in cognitive performance. It's, among the symptom improvements that we see, that's something that's sort of the most remarkable. So we know that the TMS works. We see improvement in symptoms, in cognitive performance. But there's sort of, in our lab, in the clinic, there's about 23% of patients for whom it's completely inefficient. And that's sort of associated with a lot of despondency. A lot of when patients see that it's not going to work at about day 5 or 6 of treatment, they tend to become very despondent, and their mood decreases. And then at the end, there's a huge sense of disappointment that this sort of what a lot of them perceive as the final line treatment wasn't really effective. So there's this big question: can we predict as soon as we can for what type of patient the TMS treatment is going to be efficient? And so there's a lot of it has been said about this in the literature. Here I'm going to rely on a review paper that one of our young doctors, Rok Perme, wrote. So there's a lot of credit for him for doing all this research. Typically, improvement is better in younger patients who have an episodic course of treatment. It seems to be important that there was a shorter period of different treatments that were attempted before the TMS treatment was tried. And usually it's patients with milder symptoms of depression where we see the greatest sort of improvement. There are some sort of objective biological markers that we see. The one that sort of keeps coming back in the literature, and this is going to be important later on, is the level of prefrontal cerebral perfusion and also higher metabolic activity in DLPPC. There's also some literature, but this is more limited, about the baseline metabolism in the anterior cingulate cortex. But sort of this is the stuff that we keep coming back to. So DLPPC, anterior cingulate, important areas here. In a recent review paper, they've identified that female patients tend to respond better to treatment. And they've also identified a bunch of different sort of areas in the brain where we see, when we see these patterns, the patients tend to respond better. So left DLPPC striatal connectivity being the one that sort of in the literature repeatedly pointed out that this is sort of the greatest marker that with a patient that the treatment will work for patients. A lot has been done in the recent years to use machine learning to try to predict which patients are going to respond well, and these studies are actually quite remarkable. They achieve up to 80% successful categorization based on EEG alone. In the EEG, typically what the feature is that's chosen for the classification is frontal theta activity. But what's interesting and what has been pointed out in some review papers as a potential limiting factor is that a lot of these machine learning studies only use EEG data. They don't combine that with clinical scales or any sort of estimate of how bad the symptoms are. And this is sort of, it's not really clear that what they're really predicting is treatment outcome, right? So one of the markers that has been discussed as the most reliable objective measure of both treatment outcome in the EEG, as well as a feature that's often selected for the prediction of groups where treatment is going to be successful, is theta accordance. And this is sort of, it's assumed that this is an EEG correlate of cerebral perfusion. Does that say perforation? I apologize, it's a typo. And so essentially, this was developed in the 90s at the University of California. It's a very early connectivity measure where neighboring electrodes in the EEG are correlated to see which of them correlate well, and then the uncorrelated ones are removed. So there are these, in the EEG with this striped pattern, and that supposedly correlates well to perfusion of the cerebral cortex. In a lot of recent literature reviews, that has been shown to be the most robust biomarker of treatment outcome, of symptom improvements after treatment, and this goes across the board for all sorts of treatments, ranging from TMS to psychotherapy. That seems to be a very reliable biomarker, with also predictive utility. And we've sort of replicated this effect. So when we see our patients who undergo TMS treatment, we see that there's a correlation between the increase in theta accordance and a decrease in symptom severity, as measured by IDS, which is a questionnaire. So there's now this huge question when it comes to predicting which patients to include in TMS, where we're trying to identify endophenotypes of depression. These will be sort of intermediary constructs between neurobiology and then what we see in behavior. So we're trying to identify those dimensions of functioning that are going to be useful for predicting treatment outcome. And as Jure mentioned, we're working with this framework of the four networks theory of depression, where there are four dimensions that seem to be more or less independent, which are dysphoria, negative emotions, rumination, anhedonia, and then disruption in cognitive control. So we try to evaluate patients on all of these four dimensions. And so what we typically see, and this is something that's very interesting, is that the most robust predictive factor for treatment outcome is that there's no presence of anhedonia. So there is a preserved capacity to engage in pleasurable activities. This seems to be a very robust predictor that TMS is going to work for a specific patient. And this is also something that's sort of confirmed anecdotally when we see patients undergoing treatment. If they're very despondent, very anhedonic, find no meaning, typically those are the patients that don't respond well to treatment. Another interesting phenomenon is that the presence of ruminations is associated with a negative outcome of treatment. So that seems to be to not be conducive to therapeutic outcome. And what we see is that patients who are more ill at the beginning of treatment tend to be more better than those who are less ill, which is sort of a very obvious conclusion, but still good to do a sanity check. So this is the emerging picture about what we see in our lab with our work about the predictive utilities. So we've seen that patients with cognitive dysfunctions tend to have the greatest improvement, but also patients with preserved capacity to engage in pleasurable activities. Those tend to be most responsive to treatment. Since it's still early days for our studies, that's sort of it on my part. But I do welcome any questions. Thank you very much.